Thank you for coming to our Gene Speaker Series. Tonight, we're going to have a presentation on sudden cardiac death. And our speakers include Mike Papele, who's president and founder of In a Heartbeat, a nonprofit organization to prevent death from sudden cardiac arrest. Chief Lee Goodman, who's the director of emergency medical services for the town of Trumbull and a licensed practicing EMS in the state of Connecticut. Dr. Nolan is an assistant professor in the Master of Science. And Dr. Adam, I'm sorry, could you please mute if you're not muted? Adam Olson is a clinically practicing physician assistant for a Northeast Medical Group and has been our former chair of the Department of Physician Assistant Studies and now is an adjunct faculty member with our program. So as dean this evening, I invite everybody to enjoy the presentation. I think it will be very engaging. Thank you.
Thank you very much, Dean Everson. It's a pleasure to be here with everyone, and I want to thank everyone for being here and joining us via Zoom. We're going to start off this presentation just with a video, and those via Zoom should have no problems seeing this video as well.
The ball is over, call it close, but we all know what this is gonna be. You came and failed the test, you met the best, expected chess, but got monopoly. I came in pounding, never lounging, climbing up mountains, bouncing back. Step in the ring, about you step back. They'll learn how when I get on the track. I like it louder than most. Watching all these shit just buy down to the goat. If I can't decide, I'ma probably get both. We don't celebrate, but right now I'm a toast. Resurrected ghost.
Hi, I'm Sarah McDonough-Civitello, the athletic trainer for the Quinnipiac men's basketball team.
And I'm Mike Papele, the president of In a Heartbeat Foundation. So you're working out with your teammates. What would you do if one of them collapsed? Would you be able to tell if they were in cardiac arrest? If your coach and your trainer weren't around, are you prepared to get the assist and help save their life? Watch closely as these three teammates work together and help save a life.
Jake, you okay? Oh, shoot, he's not responding. Dooley, go get the AED. I'm gonna call 911. Ace, go meet the paramedics.
If your teammate collapses and is not responding or breathing, assume they're in cardiac arrest. If someone is in cardiac arrest, follow these 3 steps. Step 1, call 911.
911, what's your emergency?
My teammate just collapsed, he's not responding. I'm gonna start CPR.
Step 2, get the AED. Step 3, begin CPR. Do you know where the AED is in your facility? If you don't, ask your coach or athletic trainer. If there's more than one person available, have someone start CPR while the other person gets the AED. When giving CPR, place your hands in the middle of the chest in line with the nipples. Push hard and fast at the rate of 100 beats per minute. If you're not comfortable giving breaths, just do compressions.
Someone in cardiac arrest cannot survive without being shocked by an AED. Use the AED as quickly as possible as soon as it arrives. Just turn it on and it will give you step-by-step directions on how to use it. You cannot hurt someone with an AED. It will only deliver a shock if necessary.
Keep performing compressions until the AED says it's analyzing. Then stand clear. Tell everyone else to stand clear for safety.
Analyzing heart rhythm. Do not touch the patient.
Stand clear, don't touch him.
Shock advised. Charging. Stand clear. Press flashing shock button. Shock 1 delivered. It is safe to touch the patient. Begin CPR now.
When I was 17 years old, I felt perfectly healthy. I was getting recruited to play college basketball. One day while working at a basketball camp, I dropped and went into cardiac arrest. Nobody started CPR right away. There was no AED on site. Because of those two circumstances, doctors said my chances of survival were 1 in a million. No one should have those odds.
If CPR is performed immediately and the AED is applied quickly, you will give your teammate the best chance of survival.
Sudden cardiac arrest can happen to anyone at any time. I challenge you to learn how to be prepared to help get an assist and save your teammate's life. For more information on In a Heartbeat and to get involved, please visit www.inaheartbeat.org to join us on our quest to save lives.
All right, I'd like to invite Chief Lee Goodman up to talk about the next portion of sudden cardiac death, which is pre-hospital response.
All right, hopefully you guys can all hear me. My considered video leads off at the perfect point because that's usually when we come in as your EMS providers and paramedics and EMTs. So I wanted to give you just a little bit of insight into what we're doing when we're there and how you can work together to really advocate for our shared goal, which is ultimately successful survival for the patient. So briefly, just touching on the out-of-hospital chain of survival. It starts with what they just showed you, which is early recognition and activation. And I want to touch briefly on recognition because I do think that that's something that people get a little overwhelmed by when you aren't used to. So in EMS, we're going in, we're expecting to see the unexpected. But even as medical professionals, as lay trainers, nurses, doctors, if you're not working in that emergency environment, your patients are normally going immediately into cardiac arrest. And we see sometimes some hesitation. People are unsure, do I start CPR? Are they breathing? Are they not breathing? If someone is unresponsive and for a minute you think they're not breathing, they probably aren't. So if you really can't get them to respond to you, go ahead and activate 911. Go ahead and start CPR. I don't know if there's anyone in this room who's done CPR. If any of you have ever done CPR on someone who is not dead, I promise they're going to let you know what I like to consider a really good sternal, right? It usually happens sometimes, it's, they're in respiratory arrest, and so they really have that very faint pulse, and they're not breathing. You jump on their chest, and 3 compressions, that's the max I've ever got to on somebody who is alive. So don't hesitate, because at least then you'll know, right? That early recognition, I know that I need to start, and then activating 911. The high quality CPR, which we're going to get into over and over again, we can't do it without that. That's what we really need. We need the CPR to stop immediately. We need the rapid defib, and I'm going to show you a little bit about that later. That's when EMS is going to come in. If it's in hospital, you're going to have your medical teams, your medical response team. I'm just
Just hit enable.
That's what I'm going to do. All right. And then we've kind of added in that post-cardiac arrest care and the recovery. That's actually a new step that we're really focusing on. It seems kind of obvious, but it hasn't always been included in that chain of survival. Got it? All right. I'm all over this technology stuff. Probably not, but I'm really good at emergencies. So stick with me. We're gonna be fine. So we really want to focus on not just having them survive that event, but getting them into a situation where they're going to get that treatment that they need, get rehabilitated, get that emotional support, and hopefully go home and live a meaningful life. So what our goal is to maximize that exact thing. How many patients can we get to go home to their families with a huge focus on being neurologically intact? And here's the thing. As a paramedic, when I arrive, I have a lot of equipment. I have a cardiac monitor. I can defibrillate all sorts of rhythms. I've got about 70 medications. I can reverse things. I've got cool airway tools. I got a drill. I can drill into some of these bones and give them all that cool medicine. But if somebody didn't start CPR before I got there, and somebody wasn't providing that oxygenated blood, how am I getting them home neurologically intact? There's a chance that I'm going to get a pulse back. I'm going to put some medication in. But if their brain wasn't getting oxygenated and their heart wasn't pumping, then really, for me, that's not a successful cardiac arrest study. And someone was asking earlier about the difference between sudden cardiac death and sudden cardiac arrest. And sudden cardiac death is someone who dies within around an hour of the onset of their symptoms. And a sudden cardiac arrest is when someone's heart stops beating and we have a chance to intervene to turn that around. So that's what our goal is. But I cannot stress this enough. I have to have those first people on scene to do that. So I kind of covered most of all of this. Just a quick understanding of what we do. It's not quite as clean and simple as you see in how you imagine a cardiac arrest. The biggest complaint we ever get is that the paramedics didn't look like they realized how. So it's very important to know the one thing we won't do is run, and the one thing we're not going to do is look frazzled, because you really don't want a frazzled paramedic. We do realize how serious it is, but we have a lot of things to do. We've got to think about exactly what they're going to need, what to get them that early therapy. We've got to figure out the best hospital that they need to go to. Do they need that cardiac cath lab, or do they need the trauma center? And those are the things that we're thinking about, as well as how on earth are we going to get them out of the house if we're stuck on the third floor. Sometimes, most times in a cardiac arrest, we stay there. So again, a lot of people will ask us, just go, why aren't you going? And the reason we're not going is because cardiac arrest is time sensitive. And if we can make a difference, it's right there. And we have everything that we need to do that. All right, that's pretty much it. So again, with the neurologically intact survival, that's what we're looking for. We want to know that we perfuse the brain enough so that when they leave, they're going to have a good life. And how we look at that is through the cerebral performance scale. 1 and 2 is our goal. Really, 1 is the ultimate goal. That means that they're going to recover and live a meaningful life with no deficits whatsoever. 2, they might have some moderate disabilities. They're conscious, they can function pretty independently, but they might have some type of memory issues, mental status changes. 3 and 4 are much more severe. 4 really is, there is no meaningful life there. You're dependent on people for every bit of support. So we really are trying to work towards eventually as many people as we can with a CPC 1 or 2. So I want to share a case with you. And before I share this case, I can't stress enough how this is my favorite cardiac arrest save ever, which as a paramedic, you should know, I didn't do anything. I call it my Uber code save, because really all the action happened before I got there. But it really was important, because there are times when I have arrived on a scene and there's been an AED right there and the patient is on the floor and the AED is still stuck there on the wall. So this was a patient who was a 22-year-old female. She was working out at the local gym. So she's 22, she's fit, she has no medical history. We consider what was there, right? So around her, there were people, there were other people. There was an AED there, and they had a phone, right? And your phone is a great resource, especially at the moment. Your communications team can really, really help with all of that. We had 2 ambulances that had BLS staff, so basic support versus advanced. Basic is your EMTs, who can do airway and CPR and are really, really critical roles. And then advanced is a paramedic who does, the airway and the medications. So the paramedics were on another call, so we only had those resources there. The patient collapsed at 2:25, and they called 911 almost immediately, so there was that early recognition. It took 2 minutes for maybe a minute and a half for us to get dispatch. So from the time the dispatcher could figure out where they were, get enough information, and we were then en route within less than a minute. So they're at a gym. What do you think? Do you think there was bystander CPR done? My favorite code save. So that's your clue. There definitely was. And not only that, I don't know how many firefighters are here today. There are my firefighter paramedics, EMTs in the audience, because there happened to be a firefighter off duty at the gym, go figure. So it was really great CPR, okay? Although just so you know, I've never shown up to be like, that's really bad CPR. Why are you doing all that? Please just do the CPR, it's fine. They had an AED, so do you think the AED was used? It actually wasn't. It actually wasn't. So why do you think that was? They might have not known where it was. They might have been intimidated and thought that they needed more training. I hear all the time, oh, I took that course 3 years ago, do you think something's changed? They might have been fearful that they were going to hurt somebody, right? So I just always remind people that the only reason we're using an AED or doing CPR is because the person is dead. We don't have to say cardiac arrest, we don't have to say fast on, we have to say the horrible word, they're dead. So you cannot make them more dead than dead, right? It's impossible. So throw the AED on, do the average compressions because you can't make them work, right? So then my BLS crew got there at 14:34 and they put the AED tags on within a minute. And that is the rhythm, they can't actually see that, but that's what went on. And within less than 1 second, they shocked that patient. So even though we didn't use the AED there, the EMTs were able to do that. You can see the shock is there given, exactly less than a second. And less than 1 minute after that shock, that patient had a bounding pulse, which by the way, was when I arrived at 14:42, 5 minutes later. They had return of spontaneous circulation. I did a 12 lead EKG, couldn't find anything wrong with them. Beautiful vitals, beautiful blood pressure. They were a little altered mental status, but everything was great. And I Ubered them to the ER. That was it. So there you can see when we pulled the records, how quickly it took, less than a minute before that. That's a beautiful sinus tap right there for someone who really wasn't breathing. They were moved to hospital, they couldn't find anything, minor laceration from some firefighter CPR, that happens. And 11 days later, she was discharged with no neurological deficits. They put an internal defibrillator in. So that's how it's done. That's why you need to use the AED. Very quickly, some stats before I pass on to Mike. But we give a lot of our statistics to the Cardiac Arrest Registry to enhance survival and analyze this data from hospitals and EMS providers. And in 2020, 45% of the patients that came into EMS with sustained return of spontaneous circulation, which means they had no pulse when we got there, they weren't breathing, and we got them back and they were still back by the time we went there. Of those, only 26 were in a shockable rhythm. But the 73% of the ones that were shocked were admitted to the hospital, and almost 50% of those were discharged with a CPC of 1 or 2, which basically means they went on to live a really meaningful life. The ones that were not in a shockable rhythm, but did get CPR, 74% of those were discharged from the hospital with that CPC 1 or 2. So there's still that big divide, and then 26 of them, they lived, but they didn't really have that functional quality of life. So it really, really is really important. And the last thing I just want to say is, whilst we do all of these statistics, every cardiac arrest that we work on is a human being. Some of them we don't get back, unfortunately, but this next speaker, we are very lucky that we did get back, and he's here to share his story. So welcome, Mike.
Thank you, Lee. That's it's interesting because I'm not a medical professional, and I'm excited to be here today. And Lee's dealt with so many of these issues, and I know there's other people in the room that have been on that side of the call, and my story is obviously completely on the other side. So you were lucky enough to see me a little bit in the video, and now you're lucky to see this very flattering picture of me for the next 15 minutes. That my mom, I still don't know why she thought it was a great idea to take this picture, but here we are. My story is, again, I'm a cardiac arrest survivor, and I'm going to kind of talk more in depth about that day and kind of what happened. But it's kind of a two-part story that I'm going to talk about to kind of led me to kind of some of the work that we do now within a heartbeat and some of the other things that I'm involved with. So starting with my, cardiac arrest survival, like I said in the video, growing up, I was a very, very healthy guy. You know, I went and saw my pediatrician every single year. You know, my mom did everything that she was supposed to do. My parents were like all over everything. You know, I went to the doctor, left, and he looked at me and said, you know, you look great. Keep doing what you're doing. You know, everything's fine. You know, you're a healthy guy. I was an athlete, played a bunch of sports growing up, and then eventually kind of focused on basketball and had this dream to play college basketball and started training at a pretty intense level. Workouts that definitely were getting my heart rate really high. Obviously, basketball is a sport where your heart rate is all over the place, where you're sprinting, stopping, and so you're up, down, all over the place. So, but there was never like a sign or a symptom that made anybody think that I could possibly have something wrong with my heart. Between my junior and senior year of high school, I spent the first half of the summer traveling like all over the East Coast, playing in all these different like showcases, AAU basketball tournaments. And again, it was like a completely normal summer. At the end of the summer, my brother and I, we were both counselors at this basketball camp that my dad had started like way beyond before we were born. And it was the week before school was about to start, and it was Wednesday night. And my brother and I decided that the next morning we were going to wake up early, go to the gym in the morning before camp started, and do a basketball workout. So the next morning, August 24th, 2006, we woke up about like 6 a.m. One of our friends picked us up and brought us over to a gym. I grew up in Wallingford, so I was actually at CHP, the prep school in Wallingford. And we did a basketball workout for like an hour and a half, and it was, you know, completely fine. I still remember it to this day, completely normal, exactly what you would think. Pretty intense. My heart rate was definitely pretty high throughout the whole thing. And after about an hour and a half, we left, went over to the Park and Recreation Center where this basketball camp was being held, where we were the counselors. And I walked in at like 8 a.m., said hi to my dad, and ordered lunch. And I don't remember anything else from that day. So from 8 to about 10:30, I was just like a camp counselor. So coach, referee, we were outside doing drills, playing games, you know, exactly what you would think. Don't remember any of that, but at 10:30, and I still don't remember this, but at 10:30, I was sitting down in the bleachers. Best friend was sitting next to me. My brother was on the court, running up and down, refereeing the game, and I just kind of took a face plant right from the front row of bleachers and just, you know, went to sudden cardiac arrest. As you learned, or as you know, many people here already know, you know, immediate CPR and a quick use of AED is ultimately what's going to save someone's life. So my friend, his first reaction was to come up to me and like kick me and be like, dude, like, what are you doing? Stop messing around. And, you know, we did have someone at the camp who came up to me that had some training, and because I was agonal gasping, didn't do CPR and made the mistake that, you know, the agonal gas meant that, you know, I was breathing and it was something else. And for whatever reason, the Parks and Recreation Center at that time, this is 2006, so maybe AEDs weren't quite as prevalent as they are now, but there was no AED in the building. Somebody was smart enough to call 911. So the reason I'm here today is because in the building next door to where I was, there was a guy sitting at his desk, just like on his computer working at his job. He was a volunteer EMT. So 911 call came through. He had his pager on. It went off. He looked at it, recognized the address. But something that's interesting about the 911 call, his code came through as like a non-emergency. So he recognized the address, got the call, and thought, okay, maybe knowing that there's camps next door, maybe like a kid broke his arm. So starts walking over, not in a hurry. Just kind of came like, maybe I can use some of my first aid training to help. As he's walking, another pager goes off again, basically alerting that it, you know, I don't know the different codes, but saying like, basically that a 17-year-old wasn't conscious on the ground, starts sprinting. Met somebody at the back door, and as he was trying to pull the door open, so took the door off his head, and probably was seriously concussed, but saw me on the ground and gave me CPR very, very well until an ambulance came, and the EMTs came in and used the defibrillator in the ambulance to shock me, and eventually got a rhythm back. So, you know, as Lee was talking about, then from there it was to Mid-State Medical Center, eventually to Connecticut Children's Medical Center, where in the beginning there was some worries about brain damage because I, was unconscious for a day, and then I had this very interesting situation where it was like someone would come into the room and I could talk to them about something that happened like 5 years ago. The second they walked out, I would have no recollection of them being in the room at all. And thankfully that passed. And, the first days I remember in the hospital, we're going through like all these tests, having an echo, having a cardiac catheterization, having a cardiac MRI, and eventually my doctor telling me that, I had a heart disease called hypertrophic cardiomyopathy. My parents, the first night in the hospital, when they told them that, something was probably wrong with my heart, my dad specifically told the doctor that he was wrong. Like, look at my healthy 17-year-old son here, that there's no way that this young guy could have something wrong with his heart, because heart disease doesn't affect young people, which was just honestly ignorance on our part. We had no clue that heart disease could affect somebody, my age. So, I had an ICD, implantable cardioverter defibrillator placed, and was told I'd never play basketball again, and basically was sent home. And in the last year, the American Heart Association has actually added recovery into the chain of survival. They had 5 planks in the chain of survival, and they just included recovery, which from a patient is really important because you go through this and you go home and it's like, okay, now you have to figure out how to live your life. It's for someone that's a kid that was not very well rounded, because all I did was play basketball, and I thought that was what defined my life. I was trying to figure that out, trying to go to college, and like you're going to learn about hypertrophic cardiomyopathy and a lot of other heart diseases, you can have a very normal life living with heart disease. So I'm going to kind of talk, that's the first half of my story. I'm going to talk quickly about the second half of my story, because I know we're out of time limit here, but as I learned to live with my disease, I was able to start working out and go to college and kind of redefine like what I wanted to do. Was coaching college basketball, actually at Quinnipiac at the time, and my ICD, like all ICDs, has a battery, and it needs to get replaced every 8 years. So it was 2014, so 8 years post cardiac arrest, post ICD implantation, and went in and had my battery changed, and it was really normal surgery. What they do is they just go in, it's very routine. They just remove the generator, because the generator just has 2 leads that are attached to your heart. They put in a new generator, they test it, and you go home in 1 day. It's pretty incredible. But like 2 weeks after the surgery, I started like feeling really sick, and was out actually one night in New Haven, and started like itching my chest, and went home, and it was red and swollen and just not looking normal. So went to my doctor, gave me some medication, and it went away. We had a road trip. We played at LaSalle in Philadelphia, and I came home and still wasn't feeling right. And then one night I started spiking like 103, 104 temperatures. And at that point, my doctor was like, "You need to come back. What can happen with these, like any surgery, I caught an infection, and the device now had to come out." So not only the generator, which is a very simple piece to remove, but also the leads that were directly attached to my heart muscle. So that's, lead extraction, which requires a laser. And as I was preparing for the surgery, they said, there is a chance that as we're doing this lead extraction, that the scar tissue around your heart muscle could rip and your heart could start bleeding. So you need to be prepped for open heart surgery, just in case this happens. There's a very, very small chance, but that's what we do. But on Thanksgiving Eve in 2014, I went in for the surgery, and about 3 hours into it, my family was sitting there, and they got the call that, they were removing the second lead, and my heart basically started bleeding in surgery, and they had a surgeon on hand. I was going to perform open heart surgery for life. So, woke up from that and had quite the recovery. I now have what's called a subcutaneous ICD, which was placed, weeks later, which is actually, I know a lot of people are familiar with the traditional pacemaker ICD that sits here. My subcutaneous ICD is actually on my side here, on my rib cage, which I've lived with now since 2015. And, like I said, I'm lucky to have have a really normal life. But that's kind of what steered me into this direction of, I'm going to talk a little bit more about our nonprofit, but after that's when we launched the organization and started doing the work that we're doing. So I'm definitely really lucky to be here. Like I said, I'm not a medical professional, so everything I'm going to be talking about is kind of from a passion and kind of basic knowledge perspective. But it's just awesome to be here and share my story and be up here with some of the other speakers. So I think we're bringing up Adam next. He's going to talk medically about hypertrophic cardiomyopathy.
Adam up.
Thank you very much. Hearing the story more than once after getting to know you, it's unbelievable what you've had to go through, and it's fascinating, and all the work you're doing now for hypertrophic cardiomyopathy and awareness is just incredible. So thank you for being here tonight with us. So what the theme of the night here is sudden cardiac death, sudden cardiac arrest, and we know that there are many different causes of sudden cardiac arrest. But we're going to really focus more on one primary cause, and that's hypertrophic cardiomyopathy. So what is hypertrophic cardiomyopathy? It's a genetic disease, and it's due to a mutation of one of several sarcomere genes, and sarcomere proteins are what make up muscle, and we're specifically targeting cardiac muscle. And it's an autosomal dominant pattern of inheritance, so thereby it's actually more common than one would think it is. And essentially, it's characterized by the development of hypertrophy, or an increase in size of the left ventricle. And this develops in the absence of other known causes that cause left ventricular hypertrophy, such as longstanding hypertension or aortic valve disease. So this is unrelated to those things. It's related more to a genetic disorder. And what I found interesting about this disorder, after learning it through my training, I'm a practicing PA in cardiology, is that although this is a genetic disorder, you're not born with a hypertrophic heart. It's something that spontaneously or develops or progresses as you age. We do see children with hypertrophic cardiomyopathy, but it's actually more common to develop this hypertrophy of the left ventricle, in late childhood, more so in adolescence, when the body growth is considerable. The body's going through puberty. We can see it in the second decade, and we can see it in the third decade. So you can be born with this quote unquote normal heart, and then start developing this spontaneous hypertrophy because you have this genetic predisposition. So as I mentioned, it is more common than we would imagine. 1 in 500 individuals are known to have this, but as we've gotten better with diagnosing it and using cardiac MRI, we've actually changed that statistic a little bit and believe it's actually more close to 1 in 200. So what's interesting too about hypertrophic cardiomyopathy is there's various morphologies of the hypertrophy. And based on those morphologies, you can have something known as hypertrophic obstructive cardiomyopathy or just hypertrophic cardiomyopathy. And when we mean obstruction, we mean obstruction of blood flow out of the heart. And on the subsequent slide, I'm going to show you what we mean by this with regards to the different patterns or morphologies of hypertrophy. I include this, and I want to give you a little bit of a basic science of this genetic disease. Is what happens when you compare on a histologic level the cardiac myocytes to normal myocardium. Although this is hypertrophied or more muscle than you would need, the muscle is not normal muscle. So these myocytes, which are the cardiac muscle cells, are in disarray. They're disorganized. There's enlarged nuclei. And then intertwined with these cardiac myocytes, you have scar tissue or fibrosis. And you also have abnormal coronary arterioles. And this leads to something known as small vessel ischemia, so reduced blood flow to this muscle that obviously needs more blood flow. It's more muscle, more blood flow, right? But you actually have reduced blood flow because of these abnormal arterioles. And this ultimately can lead to these lethal arrhythmias that we see that hypertrophic cardiomyopathy patients are prone to. And because of this disarray, these patients are prone to what was known as sudden cardiac death, and that incidence is actually about 1% annually. 1% is actually a lot. We think of it as a small number, but when you take it in the grand scheme, then 1% is a high number. So I want to just show you that this is some common morphologies of variation of hypertrophy that we see with patients with hypertrophic cardiomyopathy. You know, in this particular picture, and what we're seeing here is the heart. The heart is split down the middle from top to bottom, and we're separating front from back, and we're right about in the middle. So just to kind of get your anatomy bearings, this is the left ventricle. Left ventricle is always a larger chamber than the right ventricle, which is this right here. This is the right atrium. This is the left atrium. This is the mitral valve, the valve that separates the left atrium and left ventricle. This is your tricuspid valve, separating the right atrium from the right ventricle. And then this is your aortic valve. All right, this is the valve that allows blood to exit the heart into the main vessel called the aorta. And what you're seeing here is the left ventricle muscle. And in this particular case, this is known as a sigmoidal hypertrophic cardiomyopathy, where a segment of the interventricular septum, so this septum is what separates the two ventricles, you see that you have this local hypertrophy. So it's not the entire left ventricle in this particular variant, it's actually this region here. And what's interesting about this particular variant is this muscle can grow enough where it can obstruct the flow of blood out of the heart. And this is known as the left ventricular outflow tract. And this can get larger and block the flow of blood out of the heart. And this is what can lead to potential symptoms in patients at rest or with activity in those who actually have symptoms. This is just an example of someone having a variant of hypertrophy of the entire interventricular septum. This is known as apical hypertrophy. So this is kind of the point or the point of the bottom of the left ventricle. We call that the apex. And this is known as apical hypertrophy. And I'd like to show this because look at the size of the left ventricular cavity now. It's about half of what it should be. So you can imagine how maybe at rest, this is not a problem and most people can be asymptomatic, but as you're starting to increase your heart rate or increase your cardiac output to increase the blood flow to those vital organs with exercise, this chamber is going to shrink even more. As that heart is supposed to relax to fill with blood and then contract to push blood out, look at the smaller size here. So not enough blood is filling, which means not enough blood is going out. This can lead to low blood pressure with activity. It can lead to reduced blood flow to your coronary arteries, and that can lead to chest pain. That can lead to what we know as ischemia. These are some ways that patients can develop symptoms, but many times patients have no symptoms at all with this condition. And I just put this in here to show you the difference between obstructive versus non-obstructive. Again, they all have the gene. They all have the same risk of death annually, but the obstruction becomes a major issue with regards to symptoms. And this being the more common variant, you can see how this sigmoidal type of septum is really blocking the flow of blood out of the heart. So the aortic valve is perfectly normal. There's nothing wrong with it. But just beneath that aortic valve, you have this hypertrophied tissue not allowing blood to leave the heart. And as that heart is starting to increase the rate to keep up with that exercise, that blood flow that you need, you can just imagine how this obstruction can get even worse. So what are some of the clinical manifestations that patients have? Well, in Mike's case, none. No symptoms. He was active. He was doing all the right things that we would expect someone of his age to be doing. He was doing above that, right? He had no symptoms. But we do see in patients that do have symptoms, what could they potentially develop? Well, they can develop chest pain. That chest pain can be at rest, but more commonly with activity. They can get short of breath. They can develop palpitations related to maybe an irregular heartbeat. And the statistic, which I found also important to mention, is that obstruction we talked about, that hypertrophic obstructive cardiomyopathy, is actually present in about 30% of patients at rest, and also can be provoked by exercise in another 30% of patients. So that's about 60% of patients that are living with some type of obstruction related to this genetic disease. When as clinicians and as pre-hospital EMS personnel, what is really important to recognize when you're getting that history from a patient is taking that family history. Because family history is a predisposition we know for this condition, but also can put you into a low risk versus high risk category and changes management. So knowing if you had a family member die suddenly of premature cardiac death, whether you know the reason or not, is an important piece of history to obtain. So what about on physical examination? What could we potentially see or feel or recognize in an individual with this condition? Again, physical exam can be perfectly normal, as was the case with mine. Or sometimes it can reveal some non-specific findings. When they have a little bit of that obstruction, particularly at rest, it may cause a heart murmur that we can auscultate with the stethoscope. That heart murmur sounds like a kind of almost a blowing sound, is whoosh, whoosh, which is similar to a condition we have heard of called aortic stenosis. And that sound can change by doing various maneuvers that we're taught as clinicians. You can see a very forceful apical impulse. So when you're looking at the chest wall, you can actually see the heart beating a little bit more abnormally, more pronounced. And then if you stick your hand on the chest, you can actually feel something known as a systolic thrill, which is a vibration that a hypertrophic heart can make. Just because of all that muscle, think about it, your bicep, when you work it out, grows, right? As that muscle is squeezing, it's actually producing vibrations into that chest wall that we can feel. But some of these are non-specific, right? And in some cases, there's nothing. So how do we make the diagnosis? So when we have a high suspicion for someone with a hypertrophic cardiomyopathy, all patients should have an electrocardiogram in anyone that you suspect has this condition. A normal EKG electrocardiogram is uncommon to be normal. It's uncommon in anyone with a hypertrophic cardiomyopathy. There are specific findings on the EKG that we will see. And this is how we sometimes make the diagnosis incidentally. We just do an EKG for some various other reason why the patient's here in the emergency department or in the office for something, and we see this abnormality. What is that abnormality that we see? We typically see something known as left ventricular hypertrophy with a strain pattern. So when that muscle grows, it has more electricity. We see that electricity show up on an electrocardiogram because that's what that EKG is picking up. It's the electricity of the heart, which makes the heart squeeze. Another imaging study that we commonly do is an echocardiogram, which is an ultrasound of the heart. We do this to assess the degree of hypertrophy or increased muscle size in the heart. And just I put this here, for both medical and non-medical professionals. What we like to see in someone who has a hypertrophic cardiomyopathy is a certain minimum size. So a gray zone is between 13 to 15 millimeters, but typically anything greater than or equal to 15 millimeters anywhere when we're measuring the width of that left ventricle is diagnostic for hypertrophic cardiomyopathy. The other things we sometimes see because of this hypertrophy tissue is you get enlargement of other chambers of heart, particularly the left atrium. Another imaging test we do is an exercise stress test. Obviously in a controlled environment, we put you on a treadmill and we exercise you and we look to see whether or not you have electrocardiogram changes, electrical disturbances, and obviously symptoms. Some newer imaging studies that we do now is a cardiac MRI. Great thing about an MRI, it does not require any radiation. And we can use this for risk stratification. And then certainly we want to look for any other etiologies. In the case of someone who had a cardiac arrest, we do want to make sure it wasn't due to coronary artery disease or plaque rupture leading to a heart attack. So this is an electrocardiogram. This is actually Mike's electrocardiogram. And you can appreciate, if you have not read electrocardiogram before, this is a little difficult to explain, but what I can show you is this is completely normal. This is not a normal electrocardiogram. And what this is showing here is, number one, you see something known as T-wave inversion. So you see these waves here that are negative or below this baseline, and they're very deeply negative. One could confuse this with someone who's having coronary ischemia or a heart attack. Absolutely, this could be a heart attack type of EKG. But again, a heart attack EKG is not normal either. So just recognizing that this is not normal is important. The other thing that this has is criteria for left ventricular hypertrophy. We look at the size of this particular wave here called the S wave, and we add this to the size of this wave here called the R wave. When you add them up, if it's greater than 35 small little boxes, it equals left ventricular hypertrophy. Again, more complicated we need to get into, but what we need to recognize is this is not a normal EKG. This is just simply an echocardiogram. This is what an ultrasound of the heart looks like. Ultrasound is using sound waves, and sound waves, the probe is actually up here. Sound waves are going through the heart, bouncing back, hitting tissue, and coming back to the probe and forming an image for us. And the nice thing about an echocardiogram, it's live imaging. It's a two-dimensional picture, so we're only seeing kind of a slice. This is a long axis, three-chamber view. What we're seeing here is this is the left ventricle. This is the left atrium. This is the mitral valve. This right here is the aortic valve. You see a little bit of the LV outflow tract and the aorta. And what you can appreciate is the size of the left apex here of the ventricle. It is huge. It is thick. And if I measured from here to here, it would be 15 millimeters or greater, which would give me the diagnosis of a hypertrophic cardiomyopathy. And this is more so the apex. So let's talk a little bit about genetic testing and screening of relatives. So routine genetic testing in patients with suspected hypertrophic cardiomyopathy without clinical evaluation with an EKG and imaging is not recommended. So I have a patient who has suspected hypertrophic cardiomyopathy. I'm not going to just go right to genetic testing. That's not going to help you make the diagnosis. You want to go through a history, a physical exam, an EKG, an echocardiogram, and potentially further imaging studies to help with making that diagnosis. We do some targeted genetic screening and find it useful when you have specific conditions where perhaps some of the imaging studies are not matching up to what you felt the initial diagnosis was. Because there are some other conditions that can look like a hypertrophic cardiomyopathy. When we talk about screening relatives, when you make the diagnosis of an individual with a hypertrophic cardiomyopathy, you need to screen all first-degree relatives of the affected individual. And that is absolutely necessary. You would not be doing your job as a clinician if you're not screening the relatives. So screening involves, again, history and physical exam, doing an electrocardiogram, doing an ultrasound of the heart. We may do some genetic testing, but may recognize that there is some limitations, and about only 50% of patients will have an identifiable mutation despite having clinical findings. And in children, we very rarely will do an echocardiogram because they can have normal hearts. So the recommendation for children is to repeat annual assessments as well as echocardiograms for adolescents 12 to 18 years of age, and then every 5 years over the age of 18. Just notable about hypertrophic cardiomyopathy, what are some of the complications? Well, we certainly know about sudden cardiac arrest and sudden cardiac death being the major complication of this condition, but there's others too. Besides the symptomatology that individuals would have, we can see the development of atrial arrhythmias. Stretching of that left atrium causes erratic behavior of those electrical circuits, stretching of the electrical circuits. As they regrow, you get this disorganized arrhythmia. Atrial fib tends to be the most common atrial arrhythmia we'll see. Patients can develop syncope or passing out, and that syncopal episode can result in any kind of trauma, head trauma, fractures, motor vehicle crash. And then in long-standing hypertrophic cardiomyopathy, there's a point that left ventricle becomes burnt out. It's so large and has had to squeeze against higher pressure for so long that it actually dilates now. It enlarges. We call that a burnt out left ventricle, and that can lead to more of an end-stage weak heart or cardiomyopathy. We're going to briefly go into treatment. I mean, I can talk an hour on treatment, but I'm going to just do a very, very brief overview. So in the asymptomatic hypertrophic cardiomyopathy individual, so perhaps I did an incidental EKG, which led to further imaging studies, or we screened a family member and we realized you absolutely have this genetic condition as well and have clinical signs of it. If they're asymptomatic and are determined to be low risk, believe it or not, the current recommendations are just close clinical observation. There's been no prophylactic therapy that has seemed to alter the course of this condition. Some may advocate, well, put them on an antiarrhythmic if they're prone to these arrhythmias. Doesn't work. Put them on amiodarone, put them on lidocaine, put them on these medications that we know help to suppress these rhythms. No studies have showed that that makes a difference. So it's very close observation, it's education, helping the individual know that if you experience passing out, dizziness, chest pain, shortness of breath, your management is going to change at that point. But in the complete asymptomatic, it's close observation. The current literature says that they can participate in low to moderate exercise, providing again that they're low risk. Low risk meaning no family history of sudden cardiac death, no history of any passing out episodes, and no prior cardiac arrest where they survive. So what about the symptomatic and the high risk hypertrophic cardiomyopathy individual? Completely different story. So we don't have a cure for this condition. There's no magic pill, unfortunately, but we know how to manage it. Well, if the most lethal complication of this is an arrhythmia causing sudden cardiac arrest, then the best available therapy we have right now is the implantable cardioverter defibrillator. Small little device that's implantable in that typically goes on the left side, but we can implant on the right side for most people are righties. And we like to put on the non-dominant side. It's also easier access to the heart. It does involve most of the time a lead that goes into the major blood vessel, down into the heart, screws into the heart muscle. And really what that is there is to monitor your heart rate 24 hours a day, 7 days a week. And if it ever senses a bad heart rhythm, it's designed to charge up and shock the heart back into a normal rhythm. It's there to save your life, all right? It's not there to cure your hypertrophic cardiomyopathy. We also have some newer technology where we have leadless defibrillators, also called a subcutaneous defibrillator, where we can implant that and no lead has to go into the heart. So there's so much advanced technology that we have to treat these lethal arrhythmias. So these, what we define as high risk is any person that has a family history of cardiomyopathy related sudden cardiac death, any unexplained passing out episodes, if they have a really, really thick wall, so certainly greater than 50 millimeters, but when you get to that 30 millimeters, that puts you much higher risk for sudden cardiac death. If you have some dilation of the apex called an aneurysm, and certainly if you survived a cardiac arrest, that puts you again into that high risk category where you get an implantable defibrillator. What about for patients who have symptoms related to the hypertrophic cardiomyopathy? Well, we try to manage that medically. That's the ideal. Sometimes medically doesn't work, but medically is medications to help with chest pain, to help with some of those extra rhythm disturbances that they may have, in addition to the defibrillator. We do have some surgical options, meaning we can go in and try to remove some of that hypertrophy tissue called a myomectomy. We only do that to try to help symptoms, not to cure the disease. We can do a couple other different procedures, again, more for symptom management. But regards to physical activity, as Mike pointed out as well, they cannot compete in any competitive sports. There's some mixed literature now that came out on this, but really the current guidelines are low intensity activities like golf, bowling, yoga is okay, but anything more than that is considered much higher risk. The European Society of Cardiology did come out to show some good data, maybe supporting a little bit more moderate activity. Again, I think you sometimes have to base it on the individual. So I'd like to now welcome up Professor Julie Nolan.
Thanks, Adam. Just like the other speakers, very excited to be a part of this presentation. I'm going to specifically focus on sudden cardiac arrest in the athletic population. So I'm going to kind of go over some of the most recent epidemiological data that we have with respect to that population, talk about the importance of pre-participation exams, and then also talk about some of the current initiatives that are in place to really enhance policy development.
So we know that sudden cardiac death is the leading cause of sports-related death in athletes. We've known this for a long time. It hasn't changed, and it really is so by a wide margin. But recently, we've had some updated incidence rates that previously had been reported at about 1 in 200,000 athletes suffering a sudden cardiac arrest. But recently, that has been as high now as 1 in 50,000. So the good news is we're getting some more updated information, both with respect to overall incidence rates as well as specific conditions of what these athletes have. However, the overall incidence rate is still likely very underreported because there's no mandatory system in place that necessitates that these have to be reported. So it's only by surveillance. We also know that there's specific cohorts that are even further or higher predisposed, specifically male athletes, African Americans, and specifically within the sport of basketball. We also know that, and the speakers have kind of talked about this already, survival from sudden cardiac arrest increases substantially with proper emergency planning as well as response. And really, there's 3 specific categories that kind of go into that. One is having established emergency action plans at that venue, not only in place, but everybody involved with potentially with that athlete's care being aware of what is in the emergency action plan. The emergency action plan is actually practiced, and everyone's kind of on the same page with what their role would be if an incident would occur. Lee especially talked about the importance of AEDs previously, but having an AED on campus and also readily available for all sports competitions. So not just the AED being in the school, but if the soccer practice is being held a mile away from the school, making sure that the athletic trainer or even the coach has access to that away from the building. And then finally, making sure that athletes have access to proper medical personnel. Ideally, this involves certified athletic trainers who are employed full-time at these schools, but at the very minimum, making sure that EMS is going to be available for some of those high-risk events. And then finally, most of what I'm going to talk about is going to be specific to the high school population because we also know that health and safety policies within that cohort are rarely mandated or enforced. So that's kind of the target population where a lot of these protocols are really trying to be established and kind of better put in place to really maximize the potential outcome of these events. So we do have several best practice recommendations available. The titles that you see here are all specific to the National Athletic Trainers Association, but other entities like the American College of Sports Medicine and certainly others, a lot of the best practice recommendations certainly match up with each other. And just one item that I wanted to point out, because I'll talk a little bit more about it throughout my portion of the presentation. These best practice recommendations involve, or one thing that it involves, all competitive athletes in this country are required to undergo a pre-participation exam that includes at minimum a history and physical examination. So just looking at that, that's all well and good. However, there's no specific mandate on the components of that history section, nor what has to be done during that physical exam. So just because there's policies in place doesn't mean that they're optimal and really, targeting what we need to again, keep the student athletes safe. So as I said, I'm going to kind of focus more so on the high school population. There was a report about 10 years ago that came out that was kind of the first to really look at this in this population. And it was estimated that about 1 in 70 high schools will have a sudden cardiac arrest on campus, and about half of those will involve student athletes. What is, I guess, staggering is over 85% of those cases, it was deemed would be survivable if somebody was there to witness the event that occurred. There was, in fact, an emergency action plan that was established for that venue, and there was an AED that was available and promptly applied. So again, similar to what Mike and Lee were talking about previously. But 85% is a really good number to see with just these basic prevention strategies in place. Specific to the emergency action plan, just having that plan in place improves survival by 35%. However, especially when medical personnel are not available, it was shown that only about 34% of coaches were actually aware of the EAP and practiced the EAP. So the coach, again, in the situation where medical professionals are not there, the coach may be the person who was responsible for caring for these athletes. And again, in this particular report, only 35% actually knew about the EAP and were aware of what those protocols were. And additionally, only about 3/4 were actually trained in CPR as well as how to use an AED. So the $1 million question here is, where is the disconnect between those best policy practices that we have compared to the high rates that we're still seeing not only occurring, but the higher rate of death that are occurring when the sudden cardiac arrests are in place. So this, I kind of broke this down into two different sections, primarily based on the current research that is available, as well as some of the initiatives that are underway to establish some of these practices. So the first side of it is specific to the policy development and implementation. There's several different groups that kind of look at this specifically with sudden cardiac arrest. The one that I'll talk about briefly is the Corey Stringer Institute, who more so look at it on a broad scale with just general sudden death in sports, so that could be any cause. Both myself and Mike are involved with the Institute in various aspects. But their current initiative right now is the TUFS initiative, which stands for Teaming Up for Sport Safety. And basically what they do is they contact every state on a state-by-state level, because that's what has to be done specific to the high school population, because there's different regulations in place for each state. They try to get all of the major stakeholders in place. So that could include medical professionals, so athletic trainers, EMTs, sports medicine physicians, but also includes any other stakeholder. So it could be a principal of a school, an athletic director, somebody who has a primary role in legislation. It could be anybody. So again, they go state by state, trying to get all of these people in the same room. They kind of, they're going through education and advocacy with them, but they're also looking at the state's policy on an individual basis and trying to determine where they can be improved. Okay, so the outcome of this, while certainly is kind of tedious and takes quite a bit of time because it has to be done on an individual basis, is ultimately to improve the chance of an athlete surviving a case of not only sudden cardiac arrest, but really any form of sudden death. Excuse me that my voice is going already. And then the second part of this is more on the epidemiology side. A lot of this work is from Dr. Jonathan Dresner. Some people may be familiar with that name, and a research group from the University of Washington. But really they focus on trying to determine how to get the most up-to-date epidemiological tracking information, as well as kind of implementing some of those procedures as far as screening tools to, again, just ultimately prevent death from occurring with these sudden cardiac arrests. So the last few slides that I have are just going to briefly show some of the outcomes of the most recent initiatives with those two entities. So these first two are from the Corey Stringer Institute, and again, kind of specific to policy development. So they just about a year ago published this document, and one of the first things that they explained was that they found that there was an adoption of a greater number of components within an emergency action plan in those states that actually required those plans to be in place. Now, this isn't groundbreaking information by any means, but it does support the idea that simply having a plan in place really does go a long way and makes a difference with respect to the outcome of these cases. Secondly, however, and not quite as enthusiastic about these findings, On average, and there's certainly a wide range that you can see here among the 50 states. On average, only about 54% of best policy practices for preventing sudden death in sport were actually mandated. Okay, so either a policy wasn't in place, or if there was a policy that existed, nobody was kind of mandating that these policies were being followed. And again, you can see that there's quite a wide range among each of the 50 states. So secondly, and this, at least from my perspective, is a little bit more interesting. Just about a year ago, there was an updated epidemiology study that certainly is the most comprehensive that we have specific to the athlete population. This was a 4-year cohort study where basically they looked at all cases of sudden cardiac arrest within that 4 years. This ranged from middle school athletes all the way to professional athletes. And within that 4 years, there were 331 cases of sudden cardiac arrest. Now, if you remember a couple slides ago, I said that if all of these policies were in place and practiced accordingly, there was a chance of about 85% survival rate. But as you hopefully can see here, we certainly don't see these numbers. So there are actually more of those 331 cases, more results in death than what were actually saved. So I think it was about 54% resulted in death and 46% resulted in survival. So certainly, again, a disconnect between the potential that we have to have these cases of survival versus what we're seeing. In addition, just to kind of tease out some of the specific demographic information, almost 84% occurred in male athletes. So again, not new information that males tend to have these issues more than females, but 84% was a pretty big number. And then also most of them were occurring in the high school population. So almost 2/3 of all of the cases occurred in high school. And what's more problematic is the high school population are those who are not quite as well served with respect to proper medical coverage. So certainly a disconnect with those numbers as well. And then finally, this study also broke it down into specific etiology. So as Adam just presented, HCM, just with the general population, is by far the most common specific heart condition that is going to be prevalent in athletes. But one of the most intriguing things was within this middle school population, so younger athletes, there was actually a higher incidence of athletes having coronary artery anomalies versus HCM. And as far as I'm concerned, this is the first report to show that. Everything that we've known up to this point really has focused on HCM. And again, those numbers being much higher than some of these other causes. But this is the first to report that potentially among, again, different demographics, whether it's age, gender, etc., these athletes may be suffering from different types of heart conditions than just HCM. And that's furthermore important because, as again was presented earlier, there's different screening tools that may be more applicable based on the specific conditions they have. So this is suggesting that perhaps moving forward, there's going to be more targeted screening based on the incidence rates and epidemiological information that we're now being able to get. So collectively, again, I think the next 5 years especially is going to be really important for kind of altering clinical practice based on best practice recommendations that are currently available. Certainly prevention through emergency planning and emergency response is kind of the easiest to target. And I told you some of the initiatives that are currently underway to try to facilitate that. But secondly, effective cardiovascular screening strategies have to account for the specific etiologies most likely to produce these events. As I showed you on a previous slide, it may be important to move towards more of a targeted screening based on these different demographics. And then finally, this is gonna segue into Mike coming back up here. Regardless, EKG screening is probably the place to start. There's also reports that regardless of the specific condition that somebody has, and upwards of 70% can be detected by an EKG. So while it's not necessarily encompassing of everybody, it's going to be able to at least identify the kind of biggest proportion of athletes who may be predisposed to a sudden cardiac arrest. So with that, I'm gonna transfer back to Mike. He's gonna talk a little bit more about pre-participation screening, and specifically EKG involved in that process.
So, yeah, I'm going to talk a little bit about EKG screening, which is a slightly controversial topic amongst medical professionals. But as you can imagine, I am on the pro side of EKG screening, just for being a patient. But so basically what we've done within a heartbeat is we've launched a cardiac screening program. And it's defined as offering free electrocardiograms, ECGs, to children, teens, and young adults. So our theory behind it is that we can do some primary prevention. So we've heard about cardiac arrest and survival rates, and fortunately, a lot of things have to go really, really well. And we do know that like CPR and AED and an emergency action plan can make the survival rates really, really high, but still, things have to go really, really well for someone to survive sudden cardiac arrest. So in defining this program, we said, okay, we can try to detect kids that potentially have heart disease before they're in a situation where the survival rate still is relatively low. And like Adam showed with my EKG, if I would have had one when I was 15, 16, 17 years old prior to my event, it probably would have looked the same. And, you know, I might not have been in a situation where I almost died. So some stats here that I don't need to kind of go through, we've been talking about them, but what, you know, why screen young hearts? You know, detect, you know, all different types, can potentially detect all different types of conditions. Some stats from an organization called Parent Heart Watch, 7,000 youth each year suffering from sudden cardiac arrest. And one that I don't have on here is 1 in 300. And that's the number that they just put out, they think are of youth that are walking around with an undetected heart condition. So those are the reasons why we believe in screening. I also stole this slide from Parent Heart Watch. These are 4 young people that have unfortunately lost their lives to sudden cardiac arrest, and all had diseases that could have potentially been detected on an EKG. You know, it's just 4 examples of the many that there are. So our screening program is split 2 sides. We have a community side where we, you know, get a location. It's completely optional. Parents can sign their kids up. They sign a waiver. They show up. They get an EKG. We have a physician there that reads them, and they walk out the door with some sort of result. Either you had an EKG that's within normal limits, or there was something that we saw and we kind of guide them on this is what the follow-up should be. What I'm going to talk about today, though, is our university screening program, which is a little different. We partner with schools throughout Connecticut. So far, we've partnered with Quinnipiac University, Southern Connecticut State University, Post University, to include the EKG as part of the student-athlete pre-participation physical. So the reason why I want to talk about the importance of this program is now this isn't optional for the students. You know, this is now part of every other piece that they go through to get cleared to play a sport at their university. So basically, by us saying your ECG was normal, we're saying that we've determined that you're safe to play. So the 3 steps that we're going to talk about is the acquisition of the ECGs, the interpretation of the ECGs, and then, of course, follow-up. So starting with the acquisition, and that's kind of basically to give you an idea of how the program works. It's a partnership between us, the university, and we have an electrophysiologist named Dr. Rachel Lampert, who is at Yale New Haven, and she's an expert in, you know, interpreting student-athlete ECGs. So starting with the acquisition, you know, we determine who's acquiring them. And when acquiring an ECG, we take a lot of time to make sure that whether it's the athletic trainers, whether it's school of medicine students, nursing students, you know, volunteers that we bring in, that we're acquiring a high quality ECG. The last thing we want is that the student athlete to get their ECG, go back to their dorm, and for me to tell the athletic trainer that they have to call the student athlete to come back to redo their ECG, because that creates obviously fear, anxiety, things that we don't want to do. So we make sure we're putting them through a relatively good training program that includes some videos and actually some in-person training events where they get to practice placing electrodes. And the reason why obviously electrode placement is important. And I'm not a medical professional, so I'm not, again, I don't pretend like I am, but we had a situation come up this year in Southern Connecticut where we had some football players that were some big guys. And the doctor called and we had to bring some kids back because B5 and B6 weren't spread out enough. And basically what the doctor told me was that if what is showing on the ECG is what it is, this could be potentially something serious. But her hunch was that it was an error in the lead placement. They came back and the ECGs were actually normal. So with that, we're also talking about professionalism. A lot of times it's the first time student athletes, these young people have ever had an ECG. So explaining to them what's about to happen, taking away that fear. You're not going to feel anything. It's going to take about 30 seconds. Once we press the button, you're going to hear a beep and, just relax and breathe. And obviously privacy. We're dealing with both males and females. So we want to make sure that, we're putting people in a position where they're comfortable. Obviously there is some electrode placement that happens on the chest. Making sure that we have, up-to-date technology. And like Adam talked about before, making sure that somewhere, whether it's us asking the questions or it's on the, another part of the PPE, that the family history, symptom questions are being asked. And if yes was answered, what's the follow-up there? If we have a normal ECG that the doctor read, but there was family history of sudden death, someone before the age of 35, there's some sort of follow-up to make sure that there could be something that's related. And then we go into interpretation. And again, this is just an image that I stole from an article that I know we talked about, Dr. Dresner, that in the international criteria. Prior to this, one of the reasons why there is hesitation with mass ECG screening was the number of false positives that would come out of it. This new criteria for interpretation has lowered that number, and making sure that, again, we're working with someone who specializes in interpreting, athlete ECGs, because obviously with an athlete's heart that's strong, there could be, some enlargement in the heart. And finally, follow-up. So this is really important, especially when we're dealing with university student athletes. I was a college basketball coach for 6 years. I coach high school basketball now, and all coaches are absolutely insane, no matter what level they coach at. And what we don't want is we don't want to be holding a student athlete out for an extended period of time if they don't need to be held out. So working with Dr. Lampert and Yale and making sure that if we're doing our ECGs with Quinnipiac University on August 15th, that they have echo appointments open on August 16th. So if there's an abnormality, that student athlete can get in for an echo the next day and get either cleared to play, or obviously if it's something that could be potentially life-threatening, not. So I asked actually Dr. Lampert, I told her I was doing this, to send me some of the way she kind of goes through her follow-up. So, I know there's different levels of, it might just be echo and then cleared, and that could, be a potential structural abnormality. And then there's some other electrical diseases that could require an echo, but it also could require stress tests. It could require a meeting with the doctor, amongst other things. And obviously from there, the goal is to decrease risk. And, I know Adam talked about this a little bit, but this concept that's really been developed of this shared decision making. So, and that is basically a conversation between the doctor and the family and determining, the risk and whether it's safe to play, and ultimately making that decision if we're going to keep going or end the athlete's career. So just to kind of give you an idea, this year we did it. And, I try to stay, because of patient confidentiality, I really stay out of the results in the follow-up. But I do know that we did have one student athlete at one of the schools that had WPW, Will Parkinson's White, and was able to have it ablated and now was able to participate safely. So, we obviously really believe in the program, and we're currently trying to grow it right now and get other schools involved throughout the state of Connecticut. So, but we're really serious because we know the controversies that come with EKG screening, and we want to make sure that if we are doing it and we're getting medical professionals in our area involved, that we are doing it the right way. So, cool. And are we going back to? Wait. Cool. Awesome. Thank you.
All right, so I know it's been a long night, so I promise executive summary time. It's not my strong point, but but I really just wanted to talk a little bit about what EMS can do to help. Actually, the Corey Stringer Institute is where I found quite a lot of my passion. I was very lucky. I welcomed Sam, who was part of a lot of these studies, to Trumbull EMS about 3 years ago. In relation to sudden cardiac arrest, but through exertional heat stroke and the work that they were doing. And she invited me actually to collaborate on a couple of things with Tufts, which if any of you noticed was in the photo that your mom took that you were confused over. And that was the first thing I focused on. I was like, wow, even back then, that's, the evidence that we use is driven by what we're doing. So I became involved in that, and I actually went up to UConn to just talk to some of the athletic trainers and the physicians that were there, and I was super excited. So I rushed back to Trumbull. I reached out to the schools, to their athletic trainers. Was delighted to find that they have on-site athletic trainers, and they've actually got this really comprehensive program in place. And I think what we identified was the one missing factor was us collaborating together to get you to that 85%, right? It comes with those action plans, and the school had one, and we have one, but we didn't have a combined one. So, all credit to the school nurses at both Trumbull Middle School and high school. Over the last year, they reached out to EMS, and we worked with them on helping develop the plans that they had, their sudden cardiac arrest plans, making sure that that access to defibrillator, that everybody in the school needed to know where they were. There's several of them that are on cots, so they come out to the sports facilities. So they're always within a minimum of about a minute, maximum 2 minutes, that there's an AED there. Everybody knows what their job is. Everybody has pre-assigned roles. And what we do now is we go and we do these active drills. And I highly recommend them. And if you're an athletic trainer, if you're a student, if you're a university professor, and you're not running the drills as part of it, reach out to your local EMS department. Most of them would be only too happy to come and work with you. It really does make everything go smoothly. And no matter how much you prepare, this was our most recent drill. We were excited to be allowed into the school during COVID to do this. And that's how important it was for us to continue to do this. So what we did, we actually had the dispatchers come down, and we had them call 911, and it redirected them as if they were on the phone. And they started to work, and the dispatcher started to talk them through. So they got to experience things like the distractions of, trying to listen to the dispatcher and answer their questions whilst you're doing the CPR. And we had an ambulance on site, but we did not allow our personnel to go in until 7 minutes had passed, which, for the record, if you've worked with cardiac arrest, whether you're a medical professional or not, is a lifetime. It's a year, and it will feel like a year. But it's kind of important. And so we run that, and then we show them how to, give us the information that we might need so that we can make those decisions. That family history that you talk about, I can have a 28-year-old that is presenting with an EKG that is showing this massive heart attack, but 28 is quite young, and it's just like, it's borderline. So I'm going to delve a little bit, and when he tells me that he lost his father and nobody knows why, at 35, I'm done. I'm waking up the cardiologist, and they're just going to have to trust me. It's going to be a cardiac issue until proven otherwise, and it usually is. So letting the schools know that we need to know that. Again, when we go to the high school, I think we had one a couple of years ago, 14-year-old, and she was a sudden cardiac arrest save. We didn't have any of the history, but the plan was in place. The AED was there. Everybody did what they needed to do, and we were able to treat it as what we assumed it was, which is probably a cardiac thing, as opposed to someone who could go into an arrest from whether it's a heat stroke or a traumatic arrest. So please reach out to us. We also really want to work with advocating for change. So the reason I actually got involved with Corey Stringer was because Connecticut State protocol changed to include EMS treating exertional heat stroke right there with the big bucket of ice and not going to the hospital, because we found out that that time frame of 20 to 30 minutes can be the difference between life and death if you don't cool it down. It's pretty much the same with a lot of things. If there is something that we can be doing in the field that we're not yet doing, we can help you change that protocol. We can work with you and come up with protocols and then submit it to go through the various legislative steps it needs to go through to be implemented. We can work with our local legislators to get the mandates, because I do think some of these things should be mandated. I think the big problem is always funding. So to try to help get funded mandates so that there is funding with the training, so that we can go and do 4 sudden cardiac arrest drills a year at every school, every middle school, every high school, every university in our local town. So EMS has a lot of different connections throughout those processes. So we really just want to encourage anyone here to reach out to us and ask for our help. We love evidence-driven decisions, and we want to stay as involved as we can. And that is my executive summary. And thank you guys. I'm going to get back to that.
Wow, that was wonderful. So we want to open this up to questions. We have certainly audience here in person. We have our audience via Zoom. Dean Everson is monitoring the chat box, and any one of us are happy to come up here and answer any questions that you have. Yes.
I was wondering if there was a heart rate that you're supposed to stay below.
So the question is there a heart rate that you're supposed to stay below? And this is for a patient with a hypertrophic cardiomyopathy?
Right.
So, good question. I'll start, and if anyone wants to intervene. So patients living with hypertrophic cardiomyopathy, particularly when they have that obstruction, they do better with lower heart rates, because lower heart rates help with increased diastolic filling. So as that heart relaxes, it helps to fill that heart more when the heart rate is lower versus when it's higher. So those patients do benefit from rate lowering medications like a beta blocker or calcium channel blocker to try to get those heart rates lower. Usually less than 60 is preferred in those patients to increase diastolic filling, and which does reduce symptoms, but not in everyone. There are some patients that may benefit from some type of nitroglycerin, like a long-acting nitroglycerin, or another medication called Renexa, which helps to, same thing, we kind of relax that heart muscle.
Another question. How often for the EKGs that are done on these students are you actually finding students with anomalies?
Yeah, I could say we usually have for about every 100 that were done, I would say 4 of the 5 that Dr. Lambert had to either get in for an echo or an appointment with her, and that's on average. I know the one serious one we had this year was at WPW that required a pretty immediate ablation.
And, I actually had that same question for Mike. I said, you're doing this electrocardiogram screening. How many do you have to do to actually find an abnormality? And he gave me that statistic. But, I also look at it, an electrocardiogram is a very inexpensive modality. Cardiologists are paying for $5 per electrocardiogram interpretation by insurance company. It's peanuts to do an electrocardiogram. It's cents on the dollar. So my argument is, why not, right? And as long as you have a system in place that can ensure that you're following up these EKGs, yes, there are abnormalities or false positives, but I'd rather get worked up and ensure that that false positive is truly a false positive and not something else that might have been caught.
Do the ICDs alert their physician?
So the question was, do implantable cardioverter defibrillators, do they alert their provider if there was an arrhythmia detected or if there was a shock? And the answer is yes. Most of these devices, or all of these devices now, have Bluetooth technology. There are transmitters at home. that will communicate with that wireless device. Now, the problem with that is that you have to be within a certain range of that device when this event occurred. Now, if this was a shock, we always advise our patients with defibrillators that get a shock, just come to the emergency department, and what we can do is do an interrogation of that device. We do it right there at the bedside. It's Bluetooth technology. We just put this magnet on the device, hooked up to a computer, and we can figure out what happened. It has a memory card. It stores all the arrhythmias, and we can determine what it was. If you had an arrhythmia where you had no symptoms, what's nice about this wireless device at home is that it will communicate every single day with this wireless device. It then sends that information to a central network that we then sign on to as providers every single day, and it'll show us an alert that, Mike Smith got this, alert on a very fast rhythm, and it shows us the data. We look at the interpretation, and that may prompt me to call Mike Smith that night and say, hey, Mr. Smith, you had something concerning on the defibrillator. Why don't you come into the office? Let's take a look at it. What's going on? Any other questions from the audience? Yes.
What are the barriers, like, to getting the universities and high schools involved in starting these pre-screenings as well as in just these emergency action plans also? So what types of barriers are you seeing?
Repeat the question. Dr. Petrosini is saying, what are the barriers that high schools and some of these institutions are seeing in getting these type of policies in place or these screenings in place?
I guess the short answer is money. Again, like you said, the initial screening for EKG is $5. It's important to know that there's other conditions, so sickle cell trait, for example, in the athletic population, kind of same idea, where pre-screening drastically improves the outcome of a potential incident. And it's actually the same price. And the NCAA, ever since 2009, I believe, mandates that all incoming freshmen playing a collegiate sport has to be tested. So again, for whatever the case is, there's just still a disconnect on what we know works versus what is actually being implemented. But as far as specifically with the screening, I think money is probably the biggest barrier. But again, there also seems to be a misconception on exactly how much these things cost.
The other thing I'll say is, like, from our perspective, right now, athletic trainers especially are getting slammed with COVID too. Some of at a school like UConn, school like Yale, there's a lot of resources. They have tons of staff, tons of DAs, tons of, at a school like Post University, they don't necessarily have that. So you have a few people that are trying to handle all the COVID protocols, and then you have me saying, hey, we should include like an ECG as part, so trying to work with them to see how we can help, but also manage it because they have a lot, going on right now.
Student athlete is a freshman, sophomore, and junior and senior in high school, they have to get a physical every year before they can participate in sport. So when they go in for that physical, are you saying that does insurance not cover an EKG?
The insurance is not covered, and you don't tell me wrong, but no, unless there's a reason for that ECG, there's no insurance coverage on it. And that's, again, when we go to these schools and do this, that's part of like our pitch is like, we're screening for free, and we can acquire them all for free and get them to the doctor.
That's the problem is the insurance. The other thing I heard is I spoke to a physician at UConn once, and they were hesitant to do them even for college athletes because if they are discovered to have a problem, they could lose scholarships. And now the family's going to be up in arms, and then you get second opinions and all these problems develop from it. So I don't know if you want to speak to that too.
So just in coaching, like I said, I coached at Clemson for 3 years. We had a handful of, we had like 3 kids disqualified for actually concussion reasons. And again, Clemson had resources, but they did not lose a scholarship. They were able to keep their scholarship on like a medical term, and then the team was able to get that scholarship back and use it for recruiting. But again, I would imagine it depends on resources at the school. The school is able to afford that.
Just one more thing with that, at least specific to the sickle cell trait that I was speaking of, as far as I know, if an athlete does test positive, that information, basically HIPAA covers them, where that information doesn't have to be shared with non-medical professionals. So again, in the collegiate setting, almost all colleges have certified athletic trainers. The medical professionals would know that information, but it doesn't necessarily have to be, it doesn't have to be given to coaches. So that, you know, that concern at least potentially is alleviated with that.
I'll just speak on a little bit of the first part, just as a provider. Mike is absolutely right. Routine electrocardiogram screening for teenagers, adolescents is not covered by insurance. I have to, as a provider, have a reason or billable code. You know, so I detect a heart murmur, I can do an electrocardiogram. The patient tells me they're short of breath or they're having chest pain, I can justify an electrocardiogram. But for a well visit, a clearance for sports with no symptoms, no detectable physical exam findings, there would be no indication for an electrocardiogram at this point. Yeah, and this is again what our initiative is trying to change this. And yes, we recognize that there are these false positives, but with some of these new guidelines and algorithms coming out saying what is considered normal, what is not normal, this is how we can then push to be able to do this more often. Yes.
Other than you spoke of family history, other than a direct cardiac death, anything else that might put up a red flag?
So the question was, other than having a family history of sudden cardiac death, particularly in an immediate family, refers to be, are there other any red flags? It's all about asking the right questions. You know, so there are some individuals that are truly symptomatic, but they don't recognize that those are the symptoms. So do you ever get winded just, you know, going up a flight of stairs? You know, if you're, you know, running that mile, you know, have you noticed that your endurance is getting less and less, like you're struggling a little bit more to do it? You get more winded than you used to. You ever get some transient chest pain that you kind of put off that it's nothing? You ever feel that the heart's kind of skipping a beat or palpitations? A lot of people just ignore these symptoms as if they're, I should be getting them at times and it's probably nothing. It happens so rarely. So those can be red flags, but you have to ask the right questions. Yeah. So I would say those are the big ones. It's the symptoms and then certainly the family. So I know Chief Lee Goodman here wanted to actually just do a quick demonstration on a device that EMS commonly uses. And we just wanted to kind of show you this while we have a couple minutes here.
Thank you. Yeah, so it's just a very important part of what we do. We talk about chest compression and we talk about that, you know, recoil and allowing that chest to come out so that the heart can fill before you press down on it again. And we recently have been lucky enough that the technology keeps helping us. And we use a device that is called a Lucas device. So by paramedics and EMTs, I know you're very familiar with it, but many of you aren't. And so I actually have a colleague that's in the audience that happened to be coming tonight and offered to bring his device down. Because it's really unusual, but I think it's really important that you see the benefits of it. From a risk mitigation strategy, it's really helpful for us just because doing CPR, you know, when the ambulance is driving, that can be very challenging, but it's more about for the patient and how it really supports the perfect compressions. And, you know, when I pull out that EKG for that case that we do sometimes, you can also see the compression ratio. And you can see the difference between our CPR, the manual CPR, to when we switch to the Lucas. And you now just have this perfect compression rate and compression ratio. So, Mike, I'm going to let you speak to it because
Adam, I'm going to have the line just right for the.
We're going to go down or up. I can see the video.
Yeah.
Down.
Find the AV guy.
Is it, if you want your screen, is it down or up?
I can see his head.
Okay.
Right?
That'd be great. Okay. Here we go. Zoom out. And we can come up here. There we go. And we're going to do
See? Okay. Been in the business for about 30 years, and I've spoken to a lot of cardiac arrest survivors. But one of the things that you all know or may not have heard is that there is a difference between good CPR and not so good CPR. And the AHA guidelines state that you need to do at least 100 to 120 compressions a minute at a depth of about 2 inches on adult patients. And that can be a challenge because if anybody's done CPR in about a minute, you're pretty exhausted, especially out in the field in the summer times. After a minute, a lot of people are exhausted. Half of Connecticut is volunteers, so you've got people that are 50, 60, years old doing CPR. And what happens is after about a minute, your depth starts to suffer, and now you're only doing an inch of depth. And I download, as well as Lee, a lot of cardiac arrest cases. The average rate of chest compressions we typically see is about 150 chest compressions per minute. That's way above the AHA guidelines for correct CPR. So about 10 years ago, our company purchased a company that makes the Lucas device. And we've been selling it about 10 years. And what this does do for patients is it gives them perfect CPR every single compression. It doesn't get tired. And you can transport the patient while the Lucas is running. And you can also defibrillate someone while the Lucas is running. So I'll just give you a quick demonstration of how easy it is. We just connect it to the backboard. We press the button and it lowers the suction cup. And then we just push it up. Every compression is about 2.1 inches of depth. We can set different rates, 102, 111, or 120, depending on what the EMS provider would prefer. And we can also set this to do continuous compressions, or we can set it to do a 30-2 protocol. And that varies from state to state as far as what the protocol is. The device is really easy to deploy. Almost every town and city in Connecticut now has the Lucas device. That's how popular it's become. FDNY has like 300 of these, so it's really rapidly becoming adopted across the country and the world. And to the point now where now hospitals are starting to incorporate it into their cardiac arrest protocols, and we're starting to see survival rates improve. So it's been an amazing device, and we've seen a number of people saved. I know there was a number of people saved in trouble over the past few years, but also Bridgeport had a great save with their first usage, and that got in the paper as well. So we're very excited. The city of Waterbury is going to be getting them. So not only towns, but actually large cities are starting to fund this. And the reason why they're able to fund it is through a lot of grants, which is helping. So any questions that anybody has, I'm happy to address them. Great, thank you.
All right, thank you so much. We want to thank everyone. We know we're over our time, so we're conscious of your time as well. So we appreciate everyone coming out and joining us via Zoom, and we hope you have a wonderful night. Thank you.